So I'll just begin, okay? So today what I'm intending to cover would be your diabetic emergencies, so your hypoglycemia. We'll talk a bit about hyperglycemia and in particular your diabetic ketoacidosis and your hypoosmolar hypoglycemic state, your HHS. I'll talk a bit about variable rate insulin infusions as well, or more commonly known as sliding scales. And then lastly, we'll run through a few practical scenarios so that we can sort of revise the things that we've learned about during the session, okay? So first, we'll start with hypoglycemia. So most people will have heard of the phrase 4 is the floor. So essentially when a patient's blood sugar goes below 4 millimoles per liter, that's essentially when they are hypoglycemic, and that's when you need to do something about it, ideally. The causes of patients going hypoglycemic can be grouped into three main causes, three main groups of causes. So it could either be insulin related, or glucose related, or illness related, okay? So common reasons for patients going hypo with for insulin related reasons would be if they've been getting too strong a dose of insulin or things like glycoside, which are your sulfonylureas, if they've been getting their drugs at the wrong time, if it's interacting with different drugs, if their injection technique is poor, if they've had significant changes to their weight recently, if their renal function has changed as well recently, and also more generally, if they've become more or rather less able to cope with managing their diabetes themselves, could be because of the development of things like cognitive impairment or more acutely delirium. Also, more generally, having poor health literacy as well puts you at increased risk of getting hypoglycemia as well. And also more recently, the issue of food insecurity as well, and people not being able to eat as good a diet as they could before because of financial reasons. Also, from a glucose-related point of view, it could be if they are fasting while waiting for a procedure in hospital, or fasting in general, say for religious reasons. If they're skipping their meals, if they're too busy, also for exercise, if they exercise really intensely as well. And also for more advanced diabetics or diabetics who've been diabetic for a prolonged period of time, who get lots of hypos, they might have impaired hypo awareness as well. And also lastly, for illness-related reasons, could be if they are septic, if they've been in major trauma, if they've had burns, or if they're in multi-organ failure as well. So lots of different reasons why people can become hypoglycemic, okay? And it's important that we identify why they've gone hypoglycemic as part of like the overall management plan. So next, we're gonna talk a bit about symptoms of hypoing, okay? So I also like to categorize it into three different categories. So increased sympathetic activity, increased parasympathetic activity, and also lastly, neurological changes. So you've got your usual classic signs and symptoms like your tachycardia, palpitations, sweating, tremor, stuff like that. And also, whereas for parasympathetic, increased parasympathetic activity, you can get patients sometimes report that they feel quite hungry. And also they can be quite nauseous as well. And they can sometimes complain of tingling. And lastly, at a more advanced stage, they can experience neurological changes. So they can become more confused than normal, or conversely, they can become more drowsy than normal as well. And when it's really bad, they can get a seizure from hypoglycemia, or they can become comatose as well. Okay, so each and every trust in the UK will have its own hypoglycemia protocol. And this is the one that I've stolen from my own health board in Ayrshire and Arran. But generally your hypoglycemia protocols in your local hospital will be categorized into three different categories based on severity of the clinical presentation of a patient's hypoglycemia. And it's important that you remember that it's categorized by clinical presentation as opposed to numerical value, because it's the clinical presentation of a patient that determines how you can treat someone's hypoglycemia, okay? So if they're conscious and oriented and they can cooperate with swallowing, what you can do is that you can give them quick acting carbohydrate, 15 to 20 grams, and locally, what that would be for my patients would be things like dextrose tablets or glucojuice, which is essentially just a shot of a really sugary drink. In the past, people would give full sugar Lucozade, but nowadays you can't really get full sugar Lucozade in a hospital anymore, ever since it's brought in the ban on like sugary drinks. So it's all sugar-free Lucozade, so it's less helpful. That's why you find it less in the guidelines nowadays in your local hospitals. The important thing to do after you've given them these sorts of treatments is that you need to recheck their sugars, their blood sugar with a finger prick test 15 minutes after you've treated them to make sure that it has improved to above 4. So the cutoff is still 4 millimoles per mole. So if they are still below 4, you can repeat the same treatment again, and you can do this repeat up to 3 times to make sure that their sugars eventually go above 4. But if they are still hypoglycemic after 3 separate cycles, what you can do is that you can give IV dextrose instead, or you can give IM glucagon. Okay. And then once you've treated the hypoacutely with these treatments, what you need to do is that you need to give them a long-acting carbohydrate as well. So it could be a couple of biscuits, a slice of bread, a whole glass of milk, or even just like their next meal earlier. Okay. The next category would be for moderate hypoglycemia. So that's when patients are able to swallow and are conscious, but they're less oriented, if you will. So they're maybe a bit confused or a bit aggressive. So what you can do is that you can give them glucogel, or here the brand name here is GlucoBoost gel. So essentially you give like 1.5 to 2 full tubes of the glucogel. It looks like toothpaste almost actually. You squeeze it between their gums and their teeth, and it sort of just dissolves with the saliva, and sort of they'll passively swallow it, and some of it gets absorbed into the gums as well. Okay, and then through that you should hopefully improve their sugar readings as well. And then you should recheck their sugar after 15 minutes, same thing. And then if it's fine above 4, then fine. If it's below 4, then do it again. And then it's the same procedure essentially. And lastly, for the severe category, what you do is when a patient is unconscious or no by mouth. Okay, so that's the category for severe hypoglycemia. What you do is that you do a quick A to E assessment, identify any fixable acute causes, and then you give them IV dextrose. Okay, so IV glucose. So nowadays, guidelines recommend you give either IV 10% dextrose or 20% dextrose, and 50% dextrose is less popular nowadays because of the risk of irritation to the veins if it extravasates. Okay, so different health trusts will tell you different volumes, but usually it's 150 to 200 mils of 10% dextrose, or 75 to 100 mils of 20% dextrose. Just follow your local guidelines, okay? And then also you can also consider giving IM intramuscular glucagon. It's a 1 milligram JAG as well. It comes in a pen usually. As a one-off if you don't have IV access, or if the patient won't stay still, then you can use IM glucagon. Okay, and same thing, you check your blood sugar level after 15 minutes to make sure that it's come up. Okay, so that's the general gist for how to treat hypoglycemia based on the different categories that I've just gone over. Most wards that I've worked in actually have this thing called a hypo box. I'm not sure whether you guys have heard of it before, but essentially what it is that within that box, it contains all the drugs and the treatments that you'll need for treating a hypoglycemia ranging from mild, moderate to severe, all within that same box. So it contains like your glucose tablets, your glucogel, and also your IV dextrose as well. And it should contain a paper copy of the hypoglycemia protocol as well within the ward. Similar to how, say, for example, if you've got a patient with cardiac arrest, you should have a crash trolley in a ward. You should also have a hypo box within the ward somewhere as well. You can go ask the nurses where it's kept. Usually they should have one as well. Okay. So some important points to note in terms of hypoglycemia and how you treat it. Okay, so usually you don't omit your subsequent insulin doses, and especially your fast-acting insulin, your long-acting insulin doses, you do not omit them, and also your oral anti-hyperglycemics. Usually what you do is that you treat the hypo, and then you review their diabetic meds like regime in general to see whether there's anything you can change dose-wise to prevent this thing from happening again. Okay. And obviously, if patients are getting very severe hypos, or if they're getting recurrent hypos as well, what you can do is that you can refer to your local endocrine team or your diabetes team to get advice. Usually this comes in the form of a diabetes specialist nurse in most hospitals, as opposed to the endocrine like consultants or registrars, but your local like referral like protocol may vary depending on how the system is set up. Okay, and also one thing to note is that IM glucagon can be can potentially be ineffective in certain groups of patients, such as those with severe liver disease, or if they're malnourished, or if they're chronic alcoholics as well. And it's because glucagon activates your glycogen stores to release them, and in these groups of patients, usually they have like less adequate supplies of stores of glycogen, so you will get the resultant improvement or the resultant release of glucose as effectively with a IM glucagon JAG. Okay, so that's why you should be more cautious in these groups of patients in giving them IM glucagon. Okay, so this is the first bit about hypoglycemia done. I don't see any questions in the chat, so does anyone have any questions right now? You can just drop a message in the chat. And if not, what I'll do is that I'll move on to the next bit about hyperglycemia, okay? And so hyperglycemia technically has less fixed of a cutoff compared to hypoglycemia, okay? And that's because no one really follows this supposed cutoff value that Diabetes UK gives us of 11 millimoles per liter. Usually that's because they don't really do much at that cutoff. It's only when patients are either symptomatic or if they are actually in one of the crisis states like DK or HHS, that's usually when something actually gets done. Something significant usually gets done. But technically this is the theoretical cutoff for hyperglycemia. But I guess one of the important things that you probably will need to realize, and you'll commonly get asked to deal with as a doctor in the wards, is nurses will like page you about, oh doctor, this patient's BM is like 19. Do you need to do something about it? And then essentially they'll throw that question to you, and then it actually happens quite a bit. Patients usually have quite high BMs a lot of the time in the hospital, and eventually you guys will need to learn when you actually need to do something about it, or when you can afford to just sit and wait and see what happens and observe. Okay. So things that I think about, or things that should cross a doctor's mind when dealing with a hyperglycemic patient, is whether they're well, whether they're eating and drinking, whether you need to check ketones, whether you need to take a venous blood gas, and whether you need to consider getting a serum osmolality as well. And these things are things that you need to think about in various situations, and the things that you need to think about for each patient would vary depending on their background, as well as the kind of drugs that they're on for their diabetes. Okay. So what are some of the signs and symptoms of hyperglycemia? So usually patients will have the classic osmotic symptoms of polyuria, so peeing a lot, or polydipsia, which is being very thirsty and drinking a lot. They also can get weight loss as well unintentionally, and together these three are your classic, the classic triad for diabetes patients that you should always ask about, because they could be a sign of underlying hyperglycemia driving these symptoms. Okay. More generally, sometimes you can also get these diabetic patients having poor wound healing if they're post-op, or they've knocked themselves and they've got a open wound, or rather injured themselves and have an open wound, or if they realize that they're prone to getting recurrent infections like cellulitis or osteomyelitis, so your bone infections, and also your UTIs and your vaginal thrush and things like that, so your genitourinary infections as well. Okay, and also more generally like fatigue, and also you can sometimes get skin changes, so the classically like your acanthosis nigricans, the velvety thickening of the underarm skin, and also skin tags as well sometimes could be a sign of diabetes as well. Fine. Diagnosing diabetes. So this is sort of like a quick like recap of how to diagnose diabetes. So if a patient is symptomatic of their diabetes, and they have these blood test results, a one-off blood test results of either a random sugar above 11.1 or a fasting sugar above 7, or a post glucose tolerance test sugar of above 11.1, and they are symptomatic of their diabetes, then this is enough to clinch a diagnosis of diabetes for them, okay? But otherwise, if they are asymptomatic, then you need to repeat a set of blood tests again to make sure that they truly are diabetic. So the reason why I've put this bit down is because sometimes in the ward, sometimes you just randomly check sugar and then you'll be like taken for surprise, because you'll be like, oh, they've got a sugar of 14. Why? They don't really know why, and they don't have a known diagnosis of diabetes. So this is just something that you need to be aware of. Okay, so it's probably worth it to check one of these blood tests subsequently, like your fasting or your glucose tolerance tests. Okay. Also, you can technically diagnose diabetes with a HbA1c as well. So if their HbA1c is above 48 millimoles per mole, or 6.5%, depending on which system your health board uses, you can technically diagnose a patient with diabetes in most scenarios. There are some exceptions to the rule in which you can't use HbA1c for diagnosing diabetes. Excuse me, things like if they have got iron deficiency anemia or B12 deficiency or chronic kidney disease, or if you've had acute blood loss, things like that, that can, or if they're on things like aspirin, that will affect the analyzing of the hemoglobin in the process and things like that. But essentially, most of the time, you probably wouldn't use HbA1c for your average inpatient to diagnose them with diabetes. Usually they'll use like one of the other blood tests instead. But it's just useful to know that's another way you can diagnose diabetes in the community. Okay. Fine. So now moving on to DKA proper. So remembering the diagnostic criteria for DKA is actually quite easy because the clue is actually in the name. So how I remember it is that I just remember these three components of the name, and it tells you exactly what the diagnostic criteria are. So if you've got a high sugar above 11, if you've got raised ketones, either 2+ of urinary ketones or above 3 for your blood ketones, if your hospital has blood ketone meters, and also an acidosis on your venous blood gas, so either a pH of less than 7.3 or a bicarb of less than 18, and you've got all these three things for your patient, then technically they are in DKA and you should start treatment for DKA. Okay, so if you're ever stuck and the consultant is quizzing you in a ward round, it's these things that you need to remember. Causes of DKA. I've got two big headings again. So one, the first bit is if they have received insufficient insulin therapy, and the second bit is if they've got an increased insulin demand for various reasons. So the first bit about insufficient insulin therapy, it could be because they've got underlying undiagnosed and therefore undertreated diabetes, and so presenting in DKA is a common way in which type 1 diabetics present pre-diagnosis. And also the other main reason is because it's treatment failure in known diabetics. So say, for example, if they are on an insulin pump, if it's failed, if they've missed insulin injections, or if they're not compliant with their medications, taking their medications, that's why they can potentially go into DKA. And under increased insulin demand, you can further categorize it into stress as well as drugs, okay? So stress could be because if they've got an infection on board, if they're in the perioperative period, if they've had major trauma, or if they've had a silent myocardial infarction, okay? All these are potential reasons why patients can go into DKA. In terms of culprit drugs, common things would be steroids. It was really bad during COVID when everyone was getting dexamethasone, and then it would cause the diabetes to go out of control, because dexamethasone is a very potent steroid. Also cocaine as well can throw someone's diabetes off, diabetes control off, and also alcohol abuse as well if they've taken a whacking amount of alcohol as well. Okay. the next bit I'm going to cover is signs of severe DKA, okay? And these are just things that you should have a general awareness of, that something's not right, probably need to involve a senior. So things like cerebral edema, if they've got reduced GCS, if they're hypokalemic on their emission bloods, if their ketones are very high, if their bicarbs very low. So remember, your blood ketone cutoff is technically 3 for diagnosis. A normal bicarb should be in the low 20s normally, so 22 to 27. That's the normal range for bicarb. Bicarb 5 is very low. A pH of less than 7.1. Normal pH is usually 7.35 to 7.45. And if they are hypotensive, so if their systolic BP is less than 90, if any of these things are present, it's important that you involve a senior, either a registrar or a consultant urgently, because these patients usually will need level 2 or 3 care. And what that means is that they'll need to go to either HDU or ICU for management of their DKA, okay? And that's for usually 2 big reasons. Number one is because they are usually that unwell that they'll need a lot of intensive medical and nursing input for the treatment of their DKA. And for the second reason is because they usually will need a central venous access point. So that's usually a central line in the neck, normally for most patients. And usually these are because they're going to get lots of drugs. So these patients are usually managed in a HDU or ICU setting normally, ideally, okay? So the next bit I'm going to cover is about the pathophysiology of DKA. So this is useful for everyone to know. It's actually quite logical. So when a patient's hyperglycemic, it puts them in a hyperosmolar state, okay? And then because of that, the body will naturally just diurese and pee out lots to reduce the osmolarity. And then as a result of that, patients become hypovolemic, and that's one of the characteristics of patients in DKA, okay? They're usually very dry. And then because DKA is an insulin deficient state, that causes the increased breakdown of fats. And then because of that, you break down the fats and then you create ketones. And then particularly you get your acetoacetic acid and your beta hydroxybutyric acid, okay? And because there's lots of acid, that uses up your bicarbonate as a buffer. And then as a result, you get a metabolic acidosis with your raised anion gap, okay? So that's that bit. And then lastly, the hyperosmolar state causes potassium to shift, and also water to shift out of the cells, and then you lose it in the urine because you pee it all out. And then also because of the lack of insulin, and the insulin is not there to help promote potassium to go into the cells. And then because of that, you technically have a total body potassium deficit, okay? So all these, the 3 brown bits are essentially the clinical things that you can see in a patient's like clinical state as well as their bloods, okay? So the clinical features of DKA, so your patients will usually have your osmotic symptoms of polyuria and polydipsia, and they also probably have recent weight loss. A lot of them also complain of abdominal pain as well, and also they're usually feeling quite sick as well, okay? They're usually very dehydrated as well. They'll be tachycardic, hypotensive, and their mucous membranes will usually be quite dry. They can also have neurological abnormalities as well. They could be confused, potentially aggressive. They can complain of blurry vision, and also the really severe DKAs, they will come in comatose as well, okay? Remember, and the next bit, remember the bit I was saying about how one of the ketones that they produce is the acetoacetic acid. So that gets, you can smell it in the air and that's you classically in your exam, it'll come out as pear drop breath. Essentially, it just smells really sweet and it smells like nail varnish, essentially. It's quite a characteristic smell. Once you smell it once, you probably won't forget it. And also, in terms of the bit about them hyperventilating with the Kussmaul's breathing, how that happens is because your body is trying to blow off all the excess acid, and then so that sort of as they sort of use remember your buffer equation, so that will mean that you will blow off all the excess acid as CO2, and that's why they hyperventilate. The DKA patients will hyperventilate, okay? Okay, so there's usually usual bunch of investigations that you will order for a patient who comes in with DKA. So I've characterized it into 4 groups. So the first group is for bloods. So you usually want to get a venous blood gas. You want to check their renal function, their bicarbonate, and also a formal lab glucose as well, rather than just a finger prick glucose check, a full blood count, and also their HbA1c as well to check their sugar control over the past 3 months. Okay. You also want to check their ketones either via their urine or their blood. You should also probably consider an infection screen, and most patients will get a chest x-ray and a urine sample sent off or done, and then a lot of them will also get blood cultures done as well. And lastly, you usually will get ECG, 1 to make sure that their tachycardia is okay, and 2 to make sure that they've not had a silent MI. So the management of DKA is very complex, but the good thing is that everywhere you work, there will be a protocol in place. Where I work in Scotland, so I went to uni in Dundee and then I started working in the west of Scotland. But the good thing about being in Scotland is that there is a unified DKA protocol for the whole of Scotland. But elsewhere in England and stuff like that, you will still have your own local hospitals protocol to follow for DKA. And the reason why a protocol is in place is because there's a lot of components for the management of DKA. And it looks very simple here, but there's like multiple things they need to do at various time points upon admission. So it's usually much easier if people just follow the protocol and make sure that they do all the things on the list to make sure that everything that needs done is done. But generally, it's just 3 different main categories of things they need to do. You need to give them adequate fluids and potentially give them potassium as well to replace potassium if their potassium is low. You need to give them insulin intravenously as well at a fixed rate. And then also once their sugar falls below 14 in time, you will supplement it with a separate IV dextrose infusion as well. Okay. And there's also various blood tests that you need to do, renal function, bicarbonate and lab glucose at various time points throughout their stay initially when they come into hospital. So how do you decide whether someone has been fixed from a DKA point of view? Essentially, they need to be eating and drinking consistently. Within my health board, it's for 2 meals in a row, and they should be able to take a full portion of those meals. They also need to have their ketonemia and acidemia resolved, and also they need to be back on their normal subcutaneous insulin. Okay, so these are the 3 criteria that they need to meet in order to essentially be fixed after DKA. So this is the bit about DKA done. Do you guys have any questions at this point? Let me just have a look. Okay. So I can see that Shen's just sent me a message to ask, how can you tell the difference between DKA and hyperglycemia? So clinically, it's quite hard. It's usually because DKA, so hyperglycemia essentially in itself just literally means patient has got a high blood glucose, whereas DKA also means that they need to have a high ketones and also they need to be acidotic on their blood tests. So essentially, you need to check their bloods. At the very least, you need to at least check their urine or blood ketones, and also you need to at least do a venous blood gas to make sure that they are not acidotic. Okay, and that's the only way that you can be sure that a patient is not in DKA. It's highly unlikely for type 2 diabetics to be in DKA, although it can happen. And the risk usually is in type 1 diabetics who are hyperglycemic. Okay. Hope that answers your question. Let's see. I don't think there's any other questions. If you guys think of anything, just let me know. And hopefully that answers your question, Shen. So, let's see what you say. Oh, yeah. yeah, just type your question. So I'll explain a bit more about HHS now, and then we can sort of talk through the differences after this. Okay. So I'll address this after this bit. So HHS. HHS is a different condition compared to DKA, mainly because the diagnostic criteria is different and the patient population that get HHS usually is quite different as well. The stereotypical DKA patient that you'll get in the exams is a type 1 diabetic that's relatively young, like patients of your age or like a teenager, who has come in, as opposed to that severely unwell, as opposed to HHS. The classic HHS patient that you'll see in the exams would be a older patient, usually elderly patient, who is acutely much more confused than normal and severely dehydrated. Usually it's a type 2 diabetic as well. So that's like, it's a very different clinical like patient population that will get both conditions, although it's not a hard and fast rule actually, but that's the usual thing that we see in the hospital. Okay, so for diagnosis of HHS, patients will need to have a high serum osmolality above 320. So that is the cutoff. Okay, most places that I've worked in, you can get osmolality as a blood test that you request, but you can also technically calculate it as well using this equation at the bottom of the screen. But most places you would just send it as a blood test. Patients in HHS will also have very high blood sugars. In the 30s, 40s, 50s is not unheard of. The highest I've seen is like 70 something, which is crazy. Usually your DKA patients will be in like the teens, 20s, 30s in terms of like their blood sugar, so it's a bit less dramatic. The HHS patients usually will have a much higher blood sugar. And also these HHS patients tend to not have a significant ketonemia and not a significant acidemia as well, okay? So, and the other defining thing is that they are usually very, 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 very dry. So the pathophysiology of HHS is usually it's actually quite similar to DKA as well. But the important like distinguishing factor is that because their pancreas is still secreting small amounts of insulin, it's actually sufficient enough to still suppress the lipolysis due to the presence of the insulin. And that's why you stop the ketones from being formed, and that's why patients don't go into full-blown DKA, okay? But they still get very dehydrated and they lose their electrolytes because the predominating hyperglycemia still causes the osmotic diuresis to happen. And because the sugars are so much higher, that drives the osmolality to be much higher, and that's why they're usually much more dehydrated, okay? So the precipitating factors for HHS actually are very similar to DKA, so I probably wouldn't go through it. The only small thing that I wanted to talk about in this bit that I didn't talk about earlier was about SGLT2 inhibitors actually. So SGLT2 inhibitors are a class of diabetic medications that end in gliflozin. So your canagliflozin, dapagliflozin, and empagliflozin. This class of drugs can cause patients to go into what we call euglycemic DKA. It's a specific thing that not commonly, but it's more likely to happen in patients on SGLT2 inhibitors. And how you identify patients with euglycemic DKA is that you just have a high suspicion, essentially, for patients with who come in unwell, and you make a note to see that, oh, they're diabetic on SGLT2 inhibitor. You should check a VBG at the very least to make sure that they're not acidotic, and check their urine to make sure that they're not ketotic as well. Because euglycemic DKA patients will have okayish sugar normally, as the name implies, but they will still be ketotic and they will still be acidotic as well. I can't remember off the top of my head why euglycemic DKA happens, but it's just a common thing, or like it's a thing that can happen, especially for patients on SGLT2 inhibitors. Okay. and that's for euglycemic DKA. So sorry for that sidetrack again, but I thought it was important that I mentioned it in the context of this talk. Okay, so for HHS, a similar protocol should exist within your health board as well. And the guiding principles for treatment are essentially the same for HHS and DKA. So you give them lots of fluids and you aim for a gradual drop in their osmolality of about 3 to 8 milliosmoles per kilo per hour for these patients, and also potentially replace their potassium as well. Okay, give them insulin through the drip at a fixed rate as well to aim for a gradual decline of their blood sugar. Okay, and also once the sugar almost normalizes, give them a bit of dextrose as well to supplement it whilst the insulin continues to run. Okay, and also lastly, you should check their blood tests at regular intervals as guided by the protocol. The difference is that in HHS, you should check their osmolarity rather than the BBG, which is the case in DKA. Okay. So how do you tell when a patient is fixed from an HHS point of view? Essentially, they need to have a normal osmolarity again, so less than 300. They should have their hypovolemia corrected. Normally, how we check that is, apart from checking their renal function, is to check their urine output. Okay, so this is the minimum urine output that they should have. So for average 70 kilo person, it'll be about 35 mils an hour. That's the very least that you'll accept. Okay, the sugar should be normal as well, or at least not sky high anymore, and they should not be confused anymore. Okay, so these are like the diagnostic criteria for HHS. Okay, so actually at this point, right, I've actually come to the end of like the first bit of my talk. So you guys are feel free to like add more questions to the chat. But in the meantime, what I'll do is that I'll answer W's question about differentiating between HHS and DKA. So I've talked a bit about the different patient populations, or like the different like characteristic of like the patients that are more likely to get each condition. Usually you will need to do blood tests and check their ketones to make sure that they are not in one or the other. And usually these are the two ways that you would usually differentiate between the two diagnoses. It's usually highly unlikely that you will be suspecting both at the same time. It's more likely that one condition will be much more likely to happen in the patient sitting in front of you than the other condition. So that's what I would do. I would just check the bloods, and also check the ketones as well, just to make sure that, just to essentially make sure that I'm not missing out on a DKA or a HHS. Okay, hopefully that helps, W. Any other questions that you guys had or have? I'll give you guys like a few minutes to leave a message or type something in the chat. Okay, if there's no other questions, right? You guys, oh, hold on. It's just something that's coming. So Shin has asked, I feel that it's quite a basic question, but why would a hyperosmolar state push you into diuresis? Wouldn't the body want to retain water? So the hyperosmolar state, let's see. So the hyperosmolar state in itself is, how should I explain this? Let me think. Try to think. I'm really sorry, I can't remember the exact what exactly happens in the, essentially it's all that happens in like the kidneys. I need to go quickly read up on the osmolarity and like sorry, the stuff for what happens in terms of physiology wise, what happens in the kidneys. But essentially the patients will be really dehydrated because they're peeing out loads. But let me go read up on that and I'll get back to you after the break. Is that okay, Shen? What I'll do is that we can probably pause and take a break for now, and then we can come back at maybe 4 p.m. And then I'll continue on the next bit of my session, which will cover some practical scenarios and also a bit about sliding scales as well. Okay, and then we'll do a bit about insulin titration as well. I've had a bit of time to look up Shen's question about the osmolality, and apparently it's, excuse me, quite straightforward actually. So in terms of why a hyperosmolar state will cause you to get osmotic diuresis, essentially it's just because when you've got so much of the solutes going into like within like the collecting ducts and like the tubules essentially within the kidneys, the presence of that hyperosmolar like hyperosmolar fluid within those tubules essentially holds on to the water rather than it getting reabsorbed back into the bloodstream, and that's why it all gets peed out. So essentially that's what like I've managed to read. Essentially that's how the hyperosmolar state causes osmotic diuresis. So that's it apparently. So yeah, no worries. Okay, so this is where we left off with so we're going to start off with some insulin titration exercises. Okay, so presumably, even if you guys are in your clinical years, you probably wouldn't have had much experience with actually adjusting doses of insulin. And this is actually something that you will need to do pretty frequently actually as an FY1, even especially when you're on call and you're asked to deal with prescribing insulins when the patient's usual team is not there. And obviously most patients with diabetes and who are on insulin will not be in the diabetes ward because diabetes is so prevalent. So you will need to have at least some awareness of what to do when managing these patients. Okay, so it's probably best to start now because this was something that I felt was really lacking in medical school. I had no idea what to do with insulins actually when I graduated. Not no idea, but like very little idea of what to do realistically. Fine. So the first scenario, so you're in FY1 and you're just about to finish a busy night shift when a nurse gives you a bleep in the morning just as the sunrise, and she's concerned that her patient has had a hypo and she's not really sure whether to give the morning insulin or not. What do you do? So what I've done is that I've scanned a sample copy of my health board's insulin prescription chart, which also doubles as a blood glucose monitoring chart. And I'll just sort of talk you guys through how this chart is structured, okay? So that it'll make more sense when we're going through the scenario. So the patient's blood glucose readings and insulin prescriptions are in at four different times in the day. So pre-breakfast, pre-lunch, pre-dinner, and then lastly, pre-bedtime. So these are the usual times that patients will normally take their own insulin. And also these are the times when the nurses are supposed to check the patient's blood glucose. So notice that it's all pre-meal times, okay? So the blood glucose readings are all in these small boxes over here, okay? And then you've got, and then also you've got your insulin names, the number of units, and then lastly the prescriber's signature, and then the nurse's signature for who's given what. Okay. So a lot of you probably wouldn't be very familiar with insulins, and so you probably will have a vague awareness of the different kinds of insulins out there, like the long-acting versus the short, and then like short-acting and intermediate-acting insulins. But I probably wouldn't have much of an idea if I were to say randomly name a random brand name, like say if I said Lantus. Some of you might know that, oh, it's like a long-acting, but most of you probably wouldn't. And so it's important that you guys gain an awareness of the common brand names. It will vary in terms of trust, but and what they like to use over there, but you'll become more familiar with this with time, okay? And you should always prescribe insulins by brand name rather than the like generic name. So like, for example, you will never prescribe Glargine, but you will prescribe Lantus, kind of thing, okay? So yeah, so say for example, this one over here, Humulin M3, it is the brand name for an mixed insulin. So it's a mixed insulin because it contains an intermediate insulin as well as a fast-acting insulin. Then the name M3 means that 30% of the insulin in this is a fast-acting insulin, and then 70% of it is an intermediate acting insulin. So it lasts for quite a bit longer, up to 12 hours, okay? So because of the duration of action of the intermediate acting insulin, mixed insulins are given twice a day, okay? So for this patient, they are given pre-breakfast and pre-dinner. So, so you will see that in this case, this patient is on 8 units, pre-breakfast and pre-dinner. So going back to the scenario, right? The scenario was you were alerted to this patient because they have hypoed this morning with a blood glucose this morning of 3.4. And the nurse is asking you whether you should give the morning Humulin M3 or not, okay? Would you give it? Oh. Would you give it? Can you guys answer in the chat? Would you give or not? Yes or no? Think about it. So Shen has said yes, but reduce. Anyone else? Yes or no? Oh. No one else has really replied. Okay, so yes, technically I would still give the insulin, but the other thing that you probably should do is that you should probably reduce the insulin, okay? But the insulin, which insulin you should reduce is that you should actually reduce the nighttime insulin, okay? Not the daytime insulin. I will still give 8 units in the morning. So what in real life, what I would do is that I would treat the hypo by giving whatever's appropriate for this patient, be it glucogel, glucojuice, or IV dextrose, whatever it is. I will fix the hypo. Once the patient's sugar is above 4, I would still give the 8 units of Humulin M3. And then that night, I would reduce the pre-evening Humulin M3 dose to maybe about 6 units or 7 units instead of 8 units. The reason why I say that is because it is the nighttime insulin that affects your pre-bed insulin and your pre-breakfast insulin, because that's when that insulin is working essentially to affect the blood sugars. Okay, so you can probably see from this chart that the patient's pre-bed blood sugars actually are not very high. 6.2 and 4.7 is not very high, it's not great. And then in the mornings when they wake up, it's always been quite low. 4, 5, it's not great. So to prevent this from happening again, what you can do is that you can just permanently reduce the night Humulin M3 dose and then to a bit of a lower level, and then hopefully that should fix it once and for all, okay? Because the thing is that at night, most patients won't be eating anything once they've gone to sleep. So the only way that their sugars can go usually is down. So that's why you need to prevent this from happening again, okay? Hopefully it makes sense. Is anyone confused, or does anyone have any questions about why I did what I did?
So in case I didn't catch it right, so you're saying give glucose of some sort.
Yes.
So their levels go up a bit, and then you give the normal breakfast insulin, just adjust down the night one. Then like, if that's correct, then is there like any way you go about reducing the night one, or just?
I would just like, because you can't, you yourself as like a doctor on the ward, you can just adjust the insulin dose. You don't have to run it past anyone.
Yep. So you just reduce it by
a bit. Like, so some diabetes specialist nurses will tell you, oh, you should adjust it by a factor of whatever it is to whatever it is. But most of the time, I'll be honest and say most doctors, like 95% of doctors out there, they usually just take a guess. And then they just adjust, like, so you just, obviously you don't adjust it to like 2 units. Like you just gradually reduce it and then adjust it, and then hopefully you'll reach a level eventually with time, because with most inpatients you have time to see the effects of what your changes would have done in the days to come. So you don't have to achieve perfection within the next 24 hours. You can just reduce it slightly, and then you will see some sort of effect normally. Okay?
Yeah, I get what you mean. Thanks.
Yeah, no worries, no worries. So unfortunately, there's not really any clear hard and fast rule in terms of how much to adjust an insulin by. With experience, you will eventually sort of start to get a feel for how much to adjust insulin by. You can sort of guess in terms of how sensitive a patient is to an insulin dose change by how much insulin they're on. Say, for example, if a patient is on, say, the same regime, but like 100 units in the morning and 100 units at dinner time, you probably can adjust the dose a bit more to cause, you probably need to adjust the doses a bit more in terms of numbers wise to achieve a similar effect, because obviously they're less insulin sensitive than, say, a patient who's on, say, like 8 units per dose. So you probably would maybe decrease these patients' dose by like 1 or 2 units, but the patient on like 100 units twice a day, you probably can reduce it by like 5 or 10, and then not much would happen because their bodies they need that much insulin anyway to keep their sugars in check. So they probably will be less sensitive to a small change. Okay, but if you're not sure, just ask someone who's probably more confident. But with time, you'll probably get your own feel for like what to do. Okay, so you probably don't need to worry about like how much to change it per se. There's not really any clear hard and fast rules. Okay. Any other questions? Otherwise, what I'll do is that I'll move on to the next scenario. So this scenario, patient's about to go, you're about to go for your lunch or your night shift, okay? When the nurse bleeps you to ask, should I give the Lantus or not? My patient's fasting for an abdominal ultrasound scan at 12 noon tomorrow. So this is like in the middle of the night, okay, at like sort of like bedtime. And then the patient's gonna fast for a scan tomorrow. Do you still give the long-acting insulin? What do you do? So this is a different patient, okay? So you can see that this patient is on a slightly different insulin regime. They are on a 3 times daily NovoRapid at all their meal times, breakfast, lunch, and dinner. So that's the short-acting insulin, okay? And then you've got your long-acting insulin, your Lantus, which is given before bedtime. So it's a different regime to the previous patient who's on the twice daily mixed insulin regime, okay? So you are at this point in the night where the patient's pre-bed, they have the nurse is asking you, should you give the 12 units of Lantus that night before their scan the next day, which they will be fasting for, so they're not eating. The question is, do you give the Lantus? And I guess subsequently, do you give the morning Nova Rapid and the pre-lunch Nova Rapid? What do you do? Do you guys want to answer in the chat? Okay, I've got one answer. Does anyone else want to answer? Okay, so I've got two answers. Probably you can't probably see all of them, but essentially what I would do is that I would still give the Lantus. Okay, I would skip. I actually would skip the morning Nova Rapid, and I may or may not skip the lunchtime Nova Rapid, and I'll explain why. So the Lantus that you give at bedtime, that needs to be there in the background. So you always give the long acting in this situation, okay? The patient will go for their scan at 12 o'clock. So they will be fasted at breakfast time. Nova Rapid, which is a rapid acting insulin. So you don't really give it, when patients are fasted, because they will not get a spike in their blood sugars at breakfast because they're not eating. So they don't need the Nova Rapid then. The Lantus in the background, the long acting insulin, will act to control the sugar somewhat. The lunchtime one is a bit more of a iffy area. It depends on whether so I won't give the patient the Nova Rapid if lunch is being served and they're still on the ward but have not gone down for their scan yet. So essentially, if they're still fasted, I will not give them the Nova Rapid. If they've come back from their scan already and then they have lunch available, the key thing is whether they have lunch available to eat. If they are going to eat lunch, then I will give the Nova Rapid at lunchtime. Okay, so essentially that's what I'll do. If they're not eating, I will not give the I will not give the short acting. But I will still always give the Lantus. Okay, does that make sense? Does anyone have any questions about this?
No questions.
Okay, great stuff. Okay, so I'll just move on to the next bit. Okay, so so it's the same scenario. Okay. Oh, next bit. Is there anything else that you would change about this patient's insulin regime? So what I'll do is that I'll just bring up their chart again. Have a look at the chart. And in particular, right, I want you guys to look at the blood sugar readings throughout the course of the day. Is there any time at which it's less than ideal, at which you would change the insulin regime? Leave your answer in the chat. What would you change, if any? Okay, so W has said up the pre-dinner one. I would agree. So so you can see like the bedtime sugars are running really high, like it's 16 and 18. So that's actually really quite high. So what you can do is that you can increase the dinner time insulin. So I probably will increase it to maybe like 5, maybe 6 at dinner time, so that it can cause a change, a reduction in the pre-bed blood sugar readings, okay? And similarly for probably for pre-lunch as well, actually, I probably would increase it a bit, maybe to like 5 units at breakfast time. So I would increase the breakfast time Nova Rapid to 5 units, so that the pre-lunch sugars can come down a bit to maybe like the high single digits, maybe like 8 or 9, maybe 10. So in summary, I'll probably would increase the pre-breakfast Nova Rapid and also the pre-evening Nova Rapid. Otherwise, I probably would just leave every other like insulin dose the way that it is. Okay. Yeah. Hope that makes sense. So yeah. So this is still the same patient, but there's something else that's happened to them. So they were awaiting a package of care to go home, but unfortunately they fell in the ward and they broke their hip. So the ortho surgeons are gonna plan to take the patient to theater tomorrow, but the nurses are asking you, what should you do about the insulin? What do you do? Do you guys want to answer in the chat? Just bring up the thingy. So if they're going to theater tomorrow, what are you going to do about their insulin? Drop your answer in the chat, or you can just speak up.
I'll just guess it's the same, like a similar thing where you continue the pre-bed, but you skip the rapid ones while they are fasted or before their surgery.
Okay. So I've also got another answer similar to you as well. But actually, there is something else that you can do, or actually should do, in this scenario, and it's probably something that you guys probably have not learned about yet, but it's important that you guys know, especially for your surgical jobs in the future when dealing with patients with diabetes on insulin. Essentially, yes, I would still give the Lantus, okay, so the pre-bed long-acting insulin. But the other thing that I would do is that I would pause the short-acting. I will pause the short-acting Nova Rapids, and then start the patient instead on what we call a VRII, a variable rate insulin infusion, or what is more commonly known as a sliding scale. Okay. I'll explain a bit more about why that is the case. Essentially, the patient will be nil by mouth essentially and fasted whilst waiting for their emergency surgery. So the same rules apply that you don't give the the Novo Rapid because they're not eating. But the reason why I need to start them on a variable rate insulin infusion is because their body will eventually be undergoing a period of stress during the operation, and you need a bit more better control of their sugars within the perioperative period. And being on a variable rate insulin infusion means that a patient will get hourly fingerprint blood glucose monitoring, and that allows you to, and then also what the variable rate insulin infusion, as I'll explain later on, is that it will allow you to adjust how much short-acting insulin you give to a patient on an hourly basis. So if the sugars go up, the amount of insulin you give in that hour goes up as well. And conversely, if the blood sugar reading goes down, the amount of insulin they give to a patient is reduced in the next hour. So in a way, it's sort of like a self-correcting kind of mechanism for us to be able to control a patient's blood sugar more closely when their blood sugar control is likely to be more volatile. So going by that principle, these are the indications for when you would consider using a sliding scale. So when patients are unable to tolerate food and drink orally for a prolonged period of time, and they're on insulin, if they've been made meal by mouth and they're skipping more than one meal, and if they're vomiting or having lots of diarrhea and they're not really eating much, if they've got severe illness where they need good glycemic control, say for example, if they are profoundly septic and needing lots of drugs for support and stuff like that, and also special circumstances such as when patients are on TPN or total parenteral nutrition, so essentially nutrition through a drip, or NG feeding or enteral feeding, or if they've been given steroids, that can cause their sugars to go haywire, and also specifically for pregnant ladies in the intrapartum period, just as about to deliver, pregnant ladies who are either diabetics on insulin or gestational diabetics on insulin, they will need to go on a sliding scale as well, as they are just about to give birth in the labor ward. Okay, so these are the various scenarios in which you would come across the need for a sliding scale, and a lot of the time it will happen in a surgical ward. So it's useful for you guys to know sliding scales and how they work, because I didn't know how sliding scales worked as well. And I'll try and explain it to you from a more practical point of view, and also I'll talk through some troubleshooting ways to troubleshoot issues that you can encounter when you're looking after patients who are on a sliding scale. Okay. Oh, question. Okay, so Shen just asked, is the sliding scale just for emergency surgeries or fasting surgical procedures in general? So it's definitely for emergency surgeries for diabetics on insulin, and for fasting surgical procedures, and all of them usually end up on sliding scales anyway. The procedure that the patient was getting was just an ultrasound scan, so they were fasted, but that was because you technically could have gotten away with needing a sliding scale because you could have fed the patient at lunchtime, and then they wouldn't be fasted for too long a period of time. So most of the time you can probably get away with not starting a sliding scale. If the patient was so usually so it's quite a specific scenario. So for the ultrasound scan, usually just fast for like 6 hours beforehand. So most of the time for patients going for ultrasound scans, they don't really need to be fasted for that long. So that's why they don't usually end up on sliding scales. It's usually patients who are fasting for prolonged periods of time. That's why they will end up needing the sliding scale, because they're not eating. So their insulin requirements in that interim period when they're not eating, that's when their glycemic control, their sugar control can go haywire. Okay, I hope that makes sense. Yep, fine. So back to sliding scales. Okay, so what a sliding scale actually is or what it comprises, it essentially is 50 units of act rapid. So it's always act rapid. Okay, so it's a fast acting insulin, it's a rapid acting insulin, and these 50 units of act rapid is added to 49.5 mils of normal saline, 0.9% saline. Okay, so you don't have to exactly memorize this, but you will be expected to prescribe this. You can find this like information in like protocols in your hospital trust, so you don't have to remember it, but it'll always be this. So essentially this act rapid and the normal saline, it becomes 50 mils in a syringe. Okay, so that gives you a concentration of 1 unit per milliliter. And then this insulin solution is run into a cannula that you can see in the bottom right corner. So you can see that the left side of this is what we call an octopus with 2 legs, if you will. So the left side of it, you can see this wee like connector bit. It plugs into the end of a cannula, okay? And then you can see that there's two connector tubes that are connected to this this cannula. So you can run two separate forms of fluids into a single cannula. And that's what you will need for a sliding scale, because through one lumen of the cannula, one tube, you will be giving them the rapid insulin infusion, okay? And the other lumen, the other cannula, sorry, not cannula, the other lumen of this octopus, you'll be running what we call a substrate solution, essentially just fluids, IV fluids. And then the key thing to remember is that a sliding scale, which is the insulin solution plus the substrate solution, it should always go into one single cannula, okay? Do not allow nurses to convince you to put two separate cannulas in. It should always go into one single cannula. The reason is because if you put these two solutions into two separate cannulas and one of them blocks off for whatever reason, so say for example, if the cannula is blocked or the cannula stops working or they forget to restart after they've paused it for a while. So if you have, say for example, if you have dextrose running unopposed with no insulin running, then the patient will become hyperglycemic. And then conversely, if you have insulin running without dextrose in the background, the patient will just hypo and crash. So either way, you can't, the risk of potentially just running one without the other is too high. That's why it is always a must that a sliding scale should go into one single cannula with a connector with two lumens, so that it just goes into one vein. And if they pause it, they pause both. If they start it again, then both will run at the same time. Okay. The substrate solution ideally should be this special fluid that you can see that I've bolded over here, 0.45% saline and 5% dextrose with a bit of potassium. This is what Diabetes UK recommends, but it's not something that's commonly found in a lot of wards. So what usually happens is that the below two forms of fluids are the compromise that are sort of acceptable, less optimal, but still acceptable. So you can either get 5% dextrose with potassium, or you can get 0.18% saline with 4% dextrose and potassium. So as you can see, there's always a wee bit of dextrose within any of the solutions to provide a bit of background dextrose so that patients don't starve, and then there's some dextrose in the background to counteract the insulin that we're giving the patients. Okay, so they don't just get insulin unopposed. Okay, so essentially that's what a sliding scale comprises. So you remember I was mentioning earlier about how sliding scales give me the liberty to control how much insulin I'm giving a patient depending on what their blood sugar is. So this is a suggested chart given by Diabetes UK. Your own health board will have its own guidelines in terms of what this table will be. But essentially, it tells you that for a given blood glucose reading for that hour, how much insulin, the rate of the insulin that you should run in that 1 hour, such that it will be adequate to meet the patient's needs. So say, for example, if in that hour, the patient gets a reading of 10, that means that you would give them 2 units of Act Rapid in that 1 hour. So the insulin infusion will be running at 2 mils an hour because it's 2 units in 2 mils, okay? And then if you check their glucose in the next hour and it's shot up to 18, for example, then you can, in the next hour, you will increase the insulin infusion rate to 5 units an hour. So you can help to counteract the rise in the blood sugar. And then hopefully when you next check it in the subsequent hour after that, it will come back down to a more normal number, like say 13, and then you reduce it to 4 units. So it's an ongoing process of checking the blood sugar every hour and then adjusting the insulin rate, insulin infusion rate to whatever it is, okay? So just to go through some of the practicalities of a sliding scale. So like I said, the patients will get their blood sugars checked every hour, and then you should aim for a target range of their sugar readings to be between 6 and 10 ideally. And if you find that patients are frequently getting very high sugar readings that are not controlled on the current regime, that might mean that for a given blood sugar level, they might need a bit more insulin than the average patient. So say, for example, they might need this list of values on the right side where they need an increased rate for these insulin resistant patients. So for the given sugar level, they get more insulin per hour. Okay. Yeah, you should check their renal function daily, and you should check their fluid status. You should always assess their fluid status every day as well. So make sure they're not dehydrated, make sure they're not overloaded, things like that. And then also, most importantly, review the need for whether this patient still need to be on a sliding scale, at least on a daily basis, because it is a very labor-intensive thing to manage, especially for the nursing staff, needing to go finger prick the patients 24 hours a day, every hour. And yeah, it's also very bad for the patient because they can't sleep at night because they get finger pricks every hour, which is quite sad. Okay, so if the sugars remain out of range despite being on a sliding scale, just make sure that the cannula is working fine, the infusion equipment is working fine, and then your fluids, your substrate infusion is running at the correct rate. So most of the time it should be running at 100 mils an hour, but your guidelines will tell you what to run it at, okay? And like I said earlier, if your sugars are running too high repeatedly, then you need to increase the insulin infusion rate to the next scale, okay? And then conversely, if a patient is hypoglycemic, what you need to do is that you need to pause the insulin infusion, okay? And then so that the patient doesn't get any more insulin for that moment. And then you treat the hypo with IV dextrose, okay? Because and then so that you can fix it right away. And then you can restart the sliding scale once the sugars come above 4. So essentially once the hypo is treated. And you can then reduce the insulin infusion rate to the reduced scale. So for the same blood sugar reading, give less insulin per hour, okay? So this is probably all I was going to cover in terms of sliding scale. It probably is like a massive chunk of information that I've just thrown your way. It probably does not really make a lot of sense potentially, especially if you've not come across much to deal with sliding scales till date. But at this point, does anyone have anything that they wanted to clarify about sliding scales, or if they wanted me to explain anything about a sliding scale again? Just speak up or let me know in the chat, because it can be very confusing for people who have not dealt with sliding scales before. Give you guys a bit of time to type something if you want to. Anyone have anything that you want to ask? Nope. Okay. I'll move on to the next scenario. If you guys think of anything later on, just drop me a message in the chat or let me know at the end of this. Okay. So this is actually our last scenario. So hopefully it won't be too much longer. Okay. So your next patient has come into the clinical assessment unit. So essentially medical admissions, probably your local equivalent is called AMU, acute medical unit or whatever. It's a 22-year-old female who is a type 1 diabetic, who has come in with a few days history of loose stools and nausea and vomiting, and it's in keeping with a clinical picture of viral gastroenteritis. Okay. She's got a NEWS of 5. She's apyrexial, her temperature is 37.2. Her heart rate is slightly tachycardic at 115. BP is slightly hypotensive, 103/62. Slightly tachypneic with a respiratory rate of 22. Her oxygen stats are okay at 97% on air, and her AFPU is alert, so she's fine. So she scores a 5. On examination, she looks quite tired. Her GCS is slightly reduced at 14/15 because she's E3 out of 4. So her eyes are opening to voice. No, so, yeah, her eyes are opening to voice. And V5 is normal, and M6 is normal as well. Okay. She's got reduced skin turgor, so she's quite dry, technically. She's got a prolonged peripheral cap refill time of 3 seconds. Her chest is clear on auscultations. Heart sounds are pure. She's got a soft abdomen that is generally tender, but with no peritonism demonstrable. And she has not got any pitting edema in her legs. What kind of investigations would you guys want to order? Do you guys want to name a few things in the chat, and then we'll see what you guys come up with? Or you guys can shout it out as well if you guys want to speak. Drop a few things in chat. There's lots that you can do for in terms of investigations for her. Keeping in mind she's a type 1 diabetic.
Go do a finger prick glucose for glucose.
Yeah, because we don't have that yet, do we?
Yeah. And standard investigations, I guess you could just throw in bloods, your FBCs, use and these.
Any other blood tests you want? So Shen mentioned to me in a message, FBC, UNEs, and a VBG as well, venous blood gas. Any other blood tests that you guys can think of that might be relevant here?
I would guess like lactate, but I don't know how useful that will be.
I mean, it could be quite useful because she's got I mean, she technically has a tender abdomen, but just want to make sure that she's not profoundly like septic. And also a raised lactate would give you an idea of how much fluids she'll need. Like say, for example, a lactate of like that's really high probably means that you probably need to get quite a lot in the way of fluids as well. Okay. Let's see. So in my next slide, I've got a list of things I'll do. So the bloods I would do include FBCs, UNEs, LFTs, CRP as well, and amylase, glucose. I would want a formal lab glucose as well. So finger prick is useful there and then, but you need a formal lab glucose as well. Just so that, because it's one of the other practicalities that you guys probably won't be aware of, but when you do a finger prick glucose, right, the meters only go up to a certain number. In my trust, it's 27.8. Some places can go up to the low 30s, but if a patient has got an actual sugar reading that's really high, like in the 30s or 40s or whatever, the meter won't be able to display it. It'll literally just say more than 27.8 or whatever it is, that's the upper limit. So, or it's just say unreadable. So that's why you should send off a formal lab glucose as well. You should check the bicarbonate as well, because that's part of the DKA diagnosis requirement. And then you should do a VBG, because the VBG, when you get the blood test result, the BVG, when you take the blood, you can run it in a machine that will usually be either in like A&E or like your acute medical unit or somewhere nearby that will give you a reading and results within like a couple of minutes of you taking it. So it'll come back much faster than the formal blood test that you send off to the labs, okay? And that's very important because the VBG will give you the pH to see whether a patient is acidotic, and it will give you a glucose as well on the VBG, and it also will give you a bicarbonate on the VBG as well. So that will give you enough information to help you, and also along that, you also will need to check the ketones as well. And then with these three things, you will be able to clinch a diagnosis of DKA or refute a diagnosis of DKA, essentially, just from this this information, okay? And also because the patient's having diarrhea, you should probably get a stool sample as well, okay? So MCNS stands for microscopy, culture, and sensitivity, okay? And lastly, ECG, because the patient's tachycardic. Okay, these are like probably the basic things that I would do for a patient A&E. So like I said, because you'll get your VBG back the quickest, so these are the numbers that you see. And I've given you your reference ranges in the wee square brackets by the side, okay? Have a look at the VBG results and think about, look at it and see what's wrong with it. Which bits are off? And I'll run through it with you guys. It'll probably be a bit faster than me like asking you guys to like answer one by one. I'll cover like the important bits. Obviously, you can see that at the bottom, I've given you that the urinary ketones are 3+. So that's more than the diagnostic criteria of 2+ and above. So technically they are ketotic, okay? So in terms of the VBG, yeah, so you can see that their pH is 7.22, so that's low, so that is acidosis. Just a point to make that some health boards use H+ ion, like numbers wise, like the way to determine whether someone's acidotic or alkalotic is that they use H+ instead. So just be familiar with whatever whatever it is that your health board uses, and then just get used to that number. With time, you'll eventually know the diagnostic like reference ranges for both kinds anyway. Okay, the PO2 is low, but that's fine because it's a venous sample anyway, so you don't really care. The PCO2 is a bit low. It's fine. It's probably because they are hyperventilating and blowing off all the excess CO2, so that's why it's low. The bicarb is low at 14, which is a lot lower than 22 to 27. That is the normal reference range. The diagnostic cutoff for DKA is less than 18. Okay, so definitely the bicarb is low. The base excess is low because the normal range is -2 to 2. So -5 is quite low. Sodium's normal, potassium's safe, is 3.8. Lactate's normal, and the glucose, unsurprisingly, high. Okay, so this patient is in DKA. Just from the VBG, you can make that diagnosis already. For high sugar, raised urinary ketones, and acidosis with both a low pH and a low bicarb. Okay, and then with time, like you will eventually get the formal blood results from the lab. Okay, so the patient has got a raised white cell count of 15.2. Otherwise, the HB and platelets are normal. The sodium is fine, potassium is 3.7, okay-ish. Urea is fine, creatinine is fine, eGFR is normal. LFTs are normal. CRP is slightly raised at 22, and amylase is normal as well. Okay. And the formal lab glucose comes back at 22, so that's high. And the bicarb is low at 13. Okay. So because this patient is in DKA technically, so you should just start a DKA protocol for this patient. Okay. And then in terms of what the DKA protocol actually is, I will just quickly pause the this thingy, and then I will switch it to, hold on. I will switch it to my browser. So over here, what I have is the NHS Scotland copy of the DKA protocol. Essentially, if you guys are interested in the DKA protocol, you can go and Google NHS Scotland DKA protocol, and then the first result you see on Google should be this. Okay, so it gives you it's really long. It's 2 pages long, and there's like tons on it. So I won't go through exactly what is actually on the protocol, but essentially it gives you a list of check boxes of things you need to do when managing a patient in DKA. So if you follow the protocol, you can't go wrong. It'll tell you what investigations you need to do, what fluids you need to start, what insulin you need to give, and when to start IV dextrose, things like that. It will guide you step by step, and it tells you what to do in what period of time. So like in the first hour, in the first 4 hours, what to do, things like that. Okay, so that's what the DKA protocol gives. Fine, I will then switch back to my slides here. So sorry, this bit is just the later bit of my presentation, which I did in real life, like in person. So like I made my students go through, actually fill in the DKA protocol with these blood test results. And if you guys want, I can send like a copy of the slides as well. And then if you guys download a copy of the DKA protocol, you can sort of go through the DKA, what's it called? Like fill in the DKA protocol yourself to get an idea of what to do. And then using like these blood test results, it will tell you what are the next steps to do. Okay. So hope that will be useful for you guys as like sort of like a practical learning opportunity as well that you can do in your own time. Otherwise, that's actually it for my presentation. You can ignore the QR code because I think you're just gonna send a what's it called, a feedback form separately to collate feedback for this. I've also left my email in there, so I'm gavin.lu@nhs.scot. If you guys have any questions that you guys wanted to email me later on about anything that I've covered today, okay,